Welcome to AETCM, the emergency medicine channel. Shall we start, sir?
Yeah.
A 77-year-old male came to ER with complaints of fever with chills and breathing difficulty since last 3 days. On initial 10-second assessment, airway was patent, no pooling of secretions, no gurgling sound. Coming to breathing, SpO2 was only 71 on room air. Respiratory rate was 33 breaths per minute. We initiated him on non-invasive ventilation with FiO2 of 41% and patient was maintaining around 98%. Okay. Coming to circulation, BP was 98 by 55 mmHg, pulse rate was 70 per minute. Coming to disability,
So BP is 90.
8 per 55,
Okay.
but
How's the
patient
MAP?
is not
MAP is mean arterial pressure?
65, sir.
65. How do you calculate MAP?
2 by 3 diastole plus 1 by 3 systole. Coming to disability, GCS E4, V5, M6. Coming to exposure was afebrile. Coming to adjuvants to primary survey, ABG showed pH of 7.41, bicarb of 14.7, PCO2 of 23.7, metabolic acidosis with respiratory alkalosis picture. Okay. Potassium was 4.5, sodium was 118, lactate was 2.7 and creat of 2.80.
So creat of
2.80. Not a known case of CKD.
Not a known case of CKD. So this patient is having as AK also, right?
AK
now.
also. Sir.
So this is a patient right now came with complaints of fever with breathing difficulty
since last
and he's also having now maintaining a near normal BP MAP of 65, but patient is having a breathing difficulty, lung injury is there. Along with it, he's also having kidney injury.
AK.
So, patient is in sepsis.
Yes, sir.
Can go into septic shock. That is the condition right now the patient is in.
Yes, sir.
So what did you do for this patient?
Sir, initially, since a patient is a known case of COPD, we were suspecting an acute exacerbation of COPD, and on auscultation we got bilateral V's and Krebs. So we initiated on NEB duolin plus bronchodilators duolin plus Budocort into 3 cycles. Okay. Then also injection hydrocort 200 mg IV stat was given. And as you said, there were 2 organ dysfunction. We calculated SOFA and it was more than 3, and we came to a conclusion that there is also sepsis. So we initiated on injection. Antibiotics was initiated, and already antibiotics was given from outside hospital. So we continued the same. Piptaz was given, so we continued with Piptaz. And then on repeated BP, we got to know that patient is having a BP of 80 by 50. So and USG POCUS showed IVC were not collapsing, and bedside echo showed good LV. So we initiated on fluids and noradrenaline infusion.
Okay. So BP second on repeat examination BP was how much?
80-50, sir.
80-50. Okay.
MAP less than 65. At the same time, CBC-CRP was also showing thrombocytopenia. Coming to adjuvants, CBC-CRP showed total count of 6.4, HB of 16.
Total count of 6.4?
4, HB of 13.3, platelet of only 68,000. CRP was more than 230.
230. Okay.
So now there is thrombocytopenia also. So we were suspecting either a dengue or leptospirosis. So we had sent dengue panel, and lepto PCR also was sent. Okay. At the same time, we initiated on fluids and noradrenaline for BP fall. Okay. Initial dose of...
Okay, a patient came from outside hospital, no?
Yeah.
Did they send a blood culture there?
No, sir. Only patient was given initial management.
So, did we send for the same?
Yeah, we had sent for the blood culture at the same time.
How was the lactate of this patient?
Initially, it was 2.7.
2.7.
Since after the fall, we repeated again EBG, but there was no fall in lactate.
So, can you tell about lactate? What is hyperlactatemia? What is lactic acidosis?
Lactic acidosis is when lactate is more than 2.5.
No. Lactate more than 2 or 2.5 is hyperlactatemia, whereas lactate more than 4 is lactic acidosis. Yeah, and can you what is that? Can you classify? Do you know?
Type A and Type B. Type A is due to inadequate oxygen delivery. Causes can be hypoxia, anemia, tissue hyperperfusion, seen in shock and cardiac arrest, carbon dioxide poisoning. In type B, it is other than any causes other than inadequate oxygen delivery. It can be underlying disease or drugs like leukemia, lymphoma, thiamine deficiency, or due to less clearance like hepatic or renal failure.
So what are the normal, can you tell any drugs that cause lactic acidosis?
Metformin can cause
Okay.
lactic acidosis. Then the
Anything else?
levofloxacin,
Levofloxacin. Okay.
antipsychotics.
Antipsychotics. Can you elaborate which are the antipsychotics? Anything you know? Lithium causes.
Lithium causes.
Okay. Anything else? Any other drugs?
Phenytoin.
Phenytoin. I'll have to check upon it. Phenytoin. Any ART, antiretroviral drugs also causes lactic acidosis. So for this patient, was it type A or type B then?
It's type A.
Type A.
So,
So,
inadequate.
this patient on the next one, lactate got normal.
Not normal. It was not on increasing trend. On the second ABG.
Reduce, lactate reduce.
Same. It was 2.7 only. So
2.7.
second
So
also.
how do you calculate the lactate clearance? What is lactate? What do you mean by lactate clearance?
Lactate clearance is usually lactate is cleared by either hepatic through liver only, sir. And if it is happening in 1 hour, if lactate clearance is happening 1 hour, 10% happens in 1 hour, 60% happens in next 6 hours. Lactate clearance formula is initial lactate minus subsequent lactate by initial lactate.
Okay. So this patient,
If lactate is reducing in 10 to 20% in first 1 hour, then there is good response.
okay. So this patient never had that much of reduction was not there.
There.
For the same, we have started him on initial fluids and later on inotropic support. What all did we start?
First we started on noradrenaline.
Okay.
We started with 2 ml per hour infusion. Initial doses can be 0.05 to 0.15 mcg per kg. And depending on the perfusion and BP, we can titrate the dosage. In refractory, we can give up to 1 mcg per kg dose. Refractory shock.
Refractory shock. Okay.
And now coming to, then later on with repeated ABGs, patient showed worsening of metabolic acidosis. After 4 hours, pH became 7.14 with lactate of 7.1, with the creat of 2.90 and bicarb of 10. So we had informed nephrology consult and in the view of initiating dialysis, and 1 session of SLED was done.
Okay.
At the same time, we got our initial lab reports. Lab reports showed CKMB was elevating, HS tropi was elevating, and our lepto-PCR was positive.
Lepto-PCR came
Positive.
Okay.
CRP was 306, procal was 2.2, creatinine 2.59, TBDB also was total bilirubin and direct bilirubin was also increasing, 2.96 with 2.08. SGOT, SGPT was mildly elevated with 62.5, 78.8. Total counts were 6.21, platelet of 66,000. I've come from seeing all this and coming to a conclusion. We concluded that patient is having leptospira with organ dysfunctions, myocarditis, with transaminitis and thrombocytopenia. Heart rate initially it was 77. Initially it was 70.
Okay. ECG?
ECG showed normal sinus rhythm.
Normal sinus. No sinus tachycardia.
No, sir. Initially it was not there. But repeated after before dialysis, we repeated again. It showed sinus tachycardia. Also, we did the screening echo, which showed fair LV, and bedside poker showed bilateral B lines. So, suspecting pulmonary edema, we had initiated him on an NT-proBNP became 43,000.
43,000. How was the X-ray?
X-ray was showing pulmonary edema picture with the right lower zone consolidation.
Okay. So this patient is right now. What was the diagnosis of this patient?
There is involvement. This leptospira has 2 phases, sir. Initial phase is lepto phase or anti-icteric phase, which is a mild form. There is only fever which chills, myalgia, conjunctival suffusion, and nausea, vomiting, and rashes. But when it comes to severe or icteric phase, there is multi-organ involvement. If pulmonary involvement, we can see ARDS or diffuse pulmonary hemorrhage. If it involves hepatic dysfunction, this is due to dissemination of the same organism in the hepatocytes, which can cause a biliary blockage. This can cause elevated total bilirubin and direct bilirubin, but SGOT, SGPT increase is not seen usually in leptospira cases. And this does not require any
can be elevated,
but not in thousands. like hepatitis.
Okay.
So, and this doesn't require much of a treatment, only treatment for leptospira can reduce the TB also.
So leptospirosis phases can be divided into
Initial phase of mild lepto, anictric
phase,
and ectric phase. Ectric phase is also
what
called
about immune phase.
Biphasic leptospiremic phase and immune phase. In leptospiremic phase, it's only acute febrile illness. In immune phase, there is IgM response, and which can lead to aseptic meningitis and organ involvement.
Okay, so this patient is on which condition?
Immune
actually?
phase.
Immune phase. So this patient had leptospirosis with multi-organ dysfunction syndrome.
Yeah.
This patient had an involvement of liver, early liver, then lung injury, along with
cardiac
kidney injury.
Yeah, myocarditis
and
renal.
Myocarditis was also seen.
There. Yes.
So this is Mott's or Wheel syndrome. This is called Wheel syndrome. Right? So for the same, what is your management that we did, or what was to be done for this patient?
Usual management depending on mild or severe form Wales disease. Mild form we can start. Usually leptospira is sensitive to most of the antibiotics. For mild disease we can give doxycycline 100 mg BD, BD tablet form and Tab-Azi 500 mg OD for 7 days. This is for mild form.
Doxy or Azi
can be given. For severe diseases you can give penicillin 1.5 million units IV 6 hours or ampicillin can be given 0.5 to 1 gram in every 6 hours. Or ceftriaxone 1 gram IV every 24 hours or cefotaxime 1 gram IV every 6 hours. We can also give, depending on the involvement, we can also give piptaz, we can also give meropenem.
See, leptospira is a very like fragile organism. Any
antibiotics can
get killed.
But since from outside hospital they had initiated, we had continued with the same.
The thing is that it should be given in the initial phase. Once it crossed the immune phase, then actually then the antibiotic as such can only help with secondary infections rather than the leptospira. So anyway, right now the patient has crossed into the second phase or immune phase. So antibiotic second, like we have just given another antibiotic for the coverage too. And other than that, what did we do for like hypotension? How did you manage it?
After that, when we came to know that patient is also having myocarditis with heart failure features, we had initiated on injection Lasix and Lasix infusion, and along with Norad, we also initiated on dobutamine.
Okay, why did we initiate him on dobutamine? What is the indication for the same?
Dobutamine has beta 1, beta 2 and alpha 1 inotropic action.
Okay.
Since there is a pump failure, stroke volume has reduced and there is hyperperfusion. So this has beta 1, beta 2 and alpha action, which helps in increasing heart rate, increasing contractility, increasing stroke volume. So we initiated on.
So it will
and we started on initial Norad because initial dobutamine can cause mild vasodilation and can reduce the BP. So first we started on Norad and then dobutamine was continued.
Once BP became stable, we started on dobutamine as a drug for
cardiac failure. Yes.
Okay, so did he pick up on his BP or
yes, sir. After 4 more sessions of SLED, at the same time, patient had 2 days later, patient during the hospital stay, patient had a disorientation, and we had 2 differentials. Either it can be aseptic meningitis due to leptospira or hyponatremia, because initially 118 was the sodium, and we had sent the sodium workup, wherein blood osmolarity was 267, and there was true hyponatremia, which can be dilutional hyponatremia because there was hypervolemia in this patient.
Okay, osmolarity was on the
267.
Okay, so this is hypoosmolar
hyponatremia.
So that is
true hyponatremia.
So like how, like can you classify the hyponatremia?
Hyponatremia can be classified into either true or pseudo hyponatremia. True hyponatremia is always hypoosmolar hyponatremia. It can be divided into 3 types depending on the volume. If there is hypervolemia, it can be dilutional, seen in cardiac failure, cirrhosis, nephrotic syndrome and renal failure. If euvolemic, it is seen in SIDH or psychogenic polydipsia or glucocorticoid deficiency. If it is hypovolemia, it is seen in during diuretics, if diuretics was given, or vomiting diarrhea also we can see. Pseudo is seen in hypertriglyceridemia and hyperproteinemia in conditions like multiple myeloma.
So for this patient, we gave him like antibiotics was given, inotropic support with dobutamine was also given, and along with it we dialyzed the patient.
Yeah.
How many?
4 sessions of sled was done because BP was on lower side.
And how did we improve it?
Later on, patient started improving, sir. His CRP came down. Platelet initially was dropping, but later on it started coming up.
Okay.
Now TBDB also has become normal.
Okay.
Patient's CKMB, HS trophy, everything is dropping down. So he's becoming better now. We have titrated the dobutamine already. Now we have stopped the inotropes also.
Okay. So this patient is a leptospirosis. So if you are suspecting a leptospirosis, how do we investigate for leptospirosis? What are the normal investigations?
Normal first investigation which we can do is take a fresh urine sample and do a urine dark field microscopy, which can demonstrate live spirochetes.
Okay.
The other thing we can do is if it is in immune phase, IgM can be sent.
Okay. When do we send for the IgM?
Within first 4 days, no?
Immune phase usually after 5 days.
5 days, okay.
So after 5 days,
okay.
IgM can be positive after 5 or 6 days.
Or we can directly send PCR.
Lepto-PCR. Right now the big hospitals are having lepto-PCR. So for the PCR also we have like blood, urine. This can be sent. Initial phase we can send for the blood samples, and later on after 1 week or 10 days I think we can send for urine sample also, which can see positivity. And
other than that, we have to see all the values, sir. Renal function
can
test.
we culture for
no, sir, spirochetes cannot be cultured.
Can culture and different mediums. Then anything else? Investigations, which are investigations that we had to send for lab investigations?
All the we have to send for CBC, CRP, usually thrombocytopenia with leukocytosis are sent. RFT, if there is a renal failure, Weil's disease, we can see rise in creatinine, AK also can be seen. If LFT is also, like I told, TBDB will direct bilirubin and total bilirubin will be elevated. SGOT, HBT, not in thousands, but will be elevated. Then urine microscopy, also urine routine can be sent for to look for proteinuria, pyuria, hematuria if we are suspecting renal failure.
Then for this patient improved, right?
Yes, sir.
Okay. And inotropic support was
also stopped.
HCD was also
Stopped.
And how's this patient right now?
Right now patient is under observation. He will be discharged soon.
Okay. Anything else you want to tell?
No. Thank you, sir.